So, hello and welcome to Keele University for tonight's inaugural lecture, which is presented by Professor Toby Helliwell. My name's Christian Mallon, and I've got the privilege of being the Executive Dean here in the Faculty of Medicine and Health Sciences. Inaugural lectures are a really important part of the academic diary, as it gives us a chance to celebrate the success of our colleagues and to find out exactly what it is they do. And I'm sure that's something that Toby's family in particular are keen to find out. Professor Helliwell grew up in a small town in Monze, called Monze in Zambia, where his early curiosity about health and medicine first began. This led him to study medicine at the University of Birmingham, followed by clinical work in Australia and anaesthetics in Birmingham, before moving to North Staffordshire and Keele University to undertake academic general practice training. This period marked a turning point in his life when he really developed his research interests in polymyalgia, rheumatica, and giant cell arteritis, and you probably haven't heard of those, but by the end of the evening, you'll know an awful lot. In this inaugural lecture, Prof. Helliwell will explore the journey of his research, highlighting ongoing and future investigations for these under-researched conditions, and reflect on the wider potential of primary care to contribute to research, particularly through clinical trials and data-driven approaches. He'll also touch on his interest in global health development, which has really been a recent part of his career, but something he's very passionate about. On a personal note, it's not very often that an executive dean gets to introduce one of their best friends for their inaugural lecture, and to publicly say how proud they are of their achievements. I was, however, very surprised that he called this lecture From Monze to Medicine. I thought it'd be called Planes, Trains and Red Wine, because that seems to better reflect Toby's interest in life. Toby's intelligent, he's kind, he's caring, and he's completely oblivious to the world around him most of the time. What he is very passionate about, though, are his family, particularly his wife and his daughters, for whom he provides a 24-hour-a-day taxi service, for which they're very grateful, I'm sure. So please join me in welcoming Professor Toby Helliwell to deliver his inaugural lecture tonight.
Thanks for that very kind introduction, Christian. It's been quite stressful writing this, I've got to admit, but I spoke to Antonia the other day and she asked me, have I got any sort of pearls of wisdom and inspiration? And I said, I'm not really sure. And she said, you better make it funny then. So hopefully there's going to be a bit of interest from that point of view. But yeah, I'm going to follow, as the title said, Monze to Medicine, and then going on to the research in global health. And for those that don't know, this is Monze. It's this sort of yellow bit on the map there. And that's in the southern province of Zambia, which is a landlocked country in sub-Saharan Africa. I wasn't born there, but I went there when I was about 6 weeks old, and sort of lived a sort of really interesting and sort of idyllic life there to begin with. It had the auspicious accolade of being in the top 10 poorest countries in the world, but Monze was famous for education, really, and mum and dad sort of got jobs there, and that's how we ended up in Monze. Some interesting photos to begin with. I remember getting this as a present when I was younger, and sort of was determined to go scuba diving, and this was from my aunt and uncle who lived on the coast of Australia, but sadly, the only open water around Monze was full of sort of hippos, crocodiles, and bilharzia, which will sort of kill you quite quickly if you get on the wrong side of it. But Monze was a very sort of rural town, very basic. I mean, most of the population lived in sort of mud huts with thatched roofs. We got all our food from the local market, which was grown in people's gardens, which was great because it was all organic and all the rest of it, but it was interesting because you'd get these gluts of vegetables and all you'd be eating would be aubergines for 2.5 months. Or when it was mango season, that's the only fruit you could kind of get. But there's a picture of sort of Monze High Street, so very small, very rural. And, it was a pretty idyllic life, really. I thought you'd love that one. And, it allowed us to sort of live fairly freely and, as Christian knows, I rock the visor and I always have done. Back then, I don't know who was wearing it back to front, but that's how we rolled in those days. But largely tops off, no shoes, and funky sunglasses. But unfortunately, I did have to go to school, and as there was the kind of norm back then, you often went to boarding school. And this is me sort of in my boarding school, my first day. And as you can see, wearing that blazer, long socks and short trousers. I was really happy, as you can tell. And actually, that was taken outside of my grandma's coal and wood shed. And she taught me how to make sticks for the fire. And basically, I was chopping up bits of wood with this machete that was about this long, that if you were caught with it now, you'd probably get 10 years in prison. But I went to Old Hall and sort of, if you can have a look at that second picture, sitting next to a good friend of mine, Phil Layton, and next to him is a guy called Rick McCollum. And interestingly, we got to Birmingham University years later, and he was sat right behind me in my first lecture. So it's a small world. But I did get to go back to Zambia in the holidays, and as you can see, I'd become a bit more conservative with wearing t-shirts and shoes by then. But lots of friends, and being pulled around the garden in a box was just the best thing ever. Finished boarding school and went to Adams Grammar School, which was just basically a local grammar school. And by then we'd sort of come back to the UK. Got heavily into rugby playing, which is because it was a very sort of rugby-orientated school, and a science school, which kind of worked for me because I like the sciences. But I mentioned that I'd like to do medicine, and I was basically laughed at by my teachers because during the time that was, I think only 3 people had ever got into medicine, and they were clearly sort of had a much higher calibre than I did. But I proved them wrong, got the grades, and got into Birmingham. But didn't start Birmingham until after I'd taken a year off. Was going to go back to Zambia, but it all kind of fell through a little bit. But then I sort of got to tag on with a group of people that sort of went around the world, and sort of ended up in Australia and worked in a load of different jobs, including in a winery, which sort of, I suppose, sort of helped with my desire for wine. But one of the jobs that I did was working as a landscape gardener, and you can imagine sort of working with sort of very interesting Australians who had interesting ideas about English people. I had lots of nicknames there, and often it started with pommy and then it ended in some sort of expletive. But one of the jobs that I had to do, because as a pommy I couldn't catch, the cricket team wasn't really good at that time, was catching the turf off the back of the turf lorry. So they'd send me off to catch the turf, and I'd just be covered in mud for the rest of the day. But that was very kind of them. But I managed to save enough money and actually achieve my diving dreams, and sort of got to dive in Australia. So I got to Birmingham and somehow managed to get through Birmingham, played an awful lot of rugby. But yeah, graduated by hook or by crook. And interestingly, that top left photo is our 25-year reunion, which we had a couple of months ago. And, gosh, where the time has gone. But I still see a lot of my university friends. I've added that little picture about us, the rugby picture, because we got invited to go and play a sevens tournament at the Royal Society of Medicine. And we actually won it, and they presented us with these tankards. But I have reflected on this and thought that actually this is the only time the Royal Society is ever going to award me with anything. Slightly inside joke there, hey, Christian. But afterwards, went to Birmingham, worked at the Queen Elizabeth Hospital, and then Birmingham Heartlands Hospital. Went down to the south coast for a bit, St Richard's Hospital, and then back up to Telford. And then Antonia and I got jobs in Australia, and I worked in a place called St Vincent's Hospital, which is quite a posh-looking photo of it, but it was actually right in the middle of the red light district of King's Cross in Sydney. So we had some really interesting characters that came into our A&E. But I did get to do a brief stint at Wagga Wagga Base Hospital, which is right on the edge of the outback. But I'd show you a picture of this building, and it's a sort of 60s built monstrosity. But we had the top floor flat, but it had a absolutely wonderful view. So I came back to England and managed to get a job in anaesthetics, and I sort of wonder how I really got into anaesthetics these days, because I left university wanting to be a GP, and there's lots of theories, but I think largely it was because I had a bunch of friends who were working in Russell's Hall Hospital, and they managed to get me a job, as you could back then. But I became very disillusioned with it. My world sort of evolved around these sort of 5 syringes, and ventilating people with chlorofluorocarbons, and didn't really feel like a doctor anymore, and sort of had this mild wobble of a crisis, and wanted to leave medicine. But thankfully my aunt talked some sense into me and sort of said, go and be a GP. So off I went and applied for general practice. And at the same time, got married, had some children, and look at them, they're so embarrassed of these photos, and I love it. Look, so you'll see a few more of these girls, and actually they used to think I was funny then as well, so not anymore. But yeah, I was weirdly lucky enough to come onto get onto the North Staffordshire Vocational Training Scheme, and started my sort of work at Royal Stoke, did some various placements, but then got on. I was placed at Wolstanton Medical Centre, and at the time they had 3 GPs that were linked very heavily with Keele, so Mark Shapley, Alwyn Ralphs and John Edwards, and they really encouraged me to sort of think about doing the extra 6 months that you could do to do a bit more research and sort of get the masters. So I ended up actually going to another practice for that extra 6 months called Wells Street Medical Centre, and interestingly, that's where Antonia works now. Briefly had a job at Moorcroft Medical Centre, but then kind of got poached into Kingsbridge Medical Practice, which is where Christian worked, and Wendy Cooper, whose husband had sort of suggested that maybe I should get a job there when I was working under him in gynaecology. And what a great and supportive group of people they are at Kingsbridge. But this is where I guess the turning point for me came in terms of getting into research. You may not realise that back then, and I suppose still today, that Keele University is an international centre for osteoarthritis research. And I remember getting given this piece of paper about the projects I can do, and this is how I kind of remembered that list of projects. Someone said, "Oh, you should go and meet this person called Christian because he's in charge of that." And and so we sort of organised this meeting, and that's another turning point for my life in that first meeting in the atrium over at the medical school was when I suppose my research really my research career really started, and so I thought you've all met Christian now, but I wasn't sure how this was going to work. But so I thought I'd put a photo of him up. But what Christian really likes doing is sending you photos of him in exotic places with a beer in his hand. Although he did tell me don't use any pictures of him with a beer in his hand, but actually it's quite difficult, And I was going through my phone, can't find any photos of a Christian without a beer in his hand. But then I thought, I know, I'll just crop it out. So anyway, so I was like, I don't want to do osteoarthritis. I wasn't, I'm sure it would have been a great project, but I sort of decided to do this project in PMR and general practice. And so just as a bit of background of polymyalgia rheumatica, that's what PMR stands for. It's an inflammatory arthritis that is about as common as type 1 diabetes, so people who take insulin for their diabetes. So it's really quite common. Certainly, I know of 2 people in this room who've had it. I thought there might be a third, but not. So it's not uncommon. And what it does, it affects people's shoulders, gives a lot of pain and joint pain, their hips. They get a lot of muscle pain and fatigue, and it can be really quite disabling, really. And associated with that is an illness called giant cell arteritis, which in the medical and research world is much more sexy because it does bad things to you, like causes blindness and strokes and aneurysms and things like that. But it's a really closely associated illness. So I chose that, and it wasn't actually my first foray with PMR. I sort of have sort of nightmares still about my final GP exam when I was as an undergraduate. And I got given a bit of history and some blood tests and basically had to counsel this person about the illness that this was meant to be. And so I sat there and gave this perfect counselling session on polymyalgia rheumatica. Sadly, it was rheumatoid arthritis that she was meant to have. But I think that reflects sometimes the challenge in terms of diagnosing PMR. It can mimic lots of things. So in the master's study, it was about looking at a database that we have that's got it had 15 practices and looking at how they managed polymyalgia rheumatica. And it really sort of mirrored a study that came out by Kevin Barraclough that looked at polymyalgia rheumatica in 3 general practices. So we, just expanding it a little bit. And this study was really about looking at how GPs were managing general practice because there were guidelines out for it. We largely mirrored their findings in that GPs were doing a lot of different things, and the referral rates. This was the big thing that sort of came out to me was around sort of 80%. In their study, it was about 76%, so roughly the same. But the big point of this was that the guidelines sort of say you should refer people when they're not responding to treatment, or they're not. They've got unusual blood tests, or they're responding to treatment, but you're meant to come down off the treatment very slowly. And the treatment is steroids, and they absolutely work brilliantly for this condition. And it's one of those conditions that when you get it right, patients will come back and hug you because they've been living with this disabling condition for a while, and it's a miraculous change. But you're meant to refer them in these sort of unusual and sort of situations. And what we found was about 20% of people are being referred into hospital, but literally 99% of the research on PMR is being done on these 20% of atypical patients. And really the question was, what about the other 80% that are being managed in general practice? And I suppose that was a real key moment for us in terms of looking at further research and sort of this research trajectory that I've now been on. And I guess this is a point at which, I sort of really developed a passion for general practice and primary care research. Almost everyone is registered with a GP, and we have some of the most comprehensive longitudinal health records in the world, which gives us a really good opportunity to look at data. In 2023 and 24, almost 80% of practices achieved 90% of their QOF targets. And what QOF targets are, they're sort of governmental targets of relating to quality. And about 20% of practices are achieving 100%. So we're obviously giving a really, really good service. And in 2025, Ipsos did a GP patient survey that showed that, GPs and GPs are still, held as in very high esteem and as individuals, basically. And so it's an unparalleled environment for impactful primary care research, which is interesting because there's quite a lot of negative media out there about general practice. Not particularly. I'm trying to keep away from being too political, but our health secretary is referred to us as Luddites, I think, and building this kind of museum to 20th century medicine or something. But anyway, I'll digress. I won't dwell on that. So yeah, got the opportunity to do a PhD, and so to investigate PMR and giant cell arteritis in general practice. And this was more about sort of directly going to GPs to investigate these two illnesses. And we did that through surveys. We surveyed 5,000 people, GPs in fact, and then we also did some in-depth qualitative interviews and then sort of brought that together into our findings. And the upper photograph there is just one of the papers that we wrote out of that. I also became an OMERACT fellow, and OMERACT is this kind of they say, prestigious group that looks at international outcome measures for randomized controlled trials in rheumatology. It was a really interesting time in my life because I think a lot of them didn't know what a general practitioner was, to be honest. But that was a great opportunity to contribute a sort of primary care input into that. And at the end of the at the end of a PhD, you get to go to an event where you wear a floppy hat. But that was a great day. After that, you get to it's incredible actually doing a PhD, how many doors that opens and how, people start to take you a little bit more seriously in terms of what you're doing in terms of your research. And being a GP, I definitely have a diverse research portfolio. But I'll focus in on the PMR and GCA. I was really sort of grateful to be part of Christian's PMR cohort study, which I think to this day still is the biggest group of PMR patients we've followed up, and that was about identifying people who'd been diagnosed with PMR and then following them up. And we followed them up for 5 years. Really interesting outputs that came out of that. We've used big data to look at whether there's an association with cancer and PMR, and thankfully there's no association, although there is more diagnosis of PMR in the first 6 months. And we think that's more about people being misdiagnosed with PMR when they actually have a cancerous problem. And that has now been fed into sort of guidelines. So there's this process where, you try and exclude anything cancerous before you diagnose PMR. We've showed that there's some increase in cardiovascular risk, but there's no increase in death, interestingly. And when I was doing my PhD in polymyalgia rheumatica, someone came up to me and said, "Can you really do a PhD in polymyalgia rheumatica?" And thankfully, I think I certainly know of 3 PhDs that's now been done in PMR. So there's obviously lots of work to do. And one of our sort of very bright PhD students did lots of work on data and actually dispelled this myth that PMR is a kind of short-lived illness. And actually 25% of people are still having to have treatment after 4 years. And I'm really proud, actually, that I've been part of a group of people that have become world experts, really, in PMR. And actually, there's a website called Expertscape, but the website's been down, so I've not been able to get a screen grab. But I think if you go on there, certainly I think, we have 4 people from Keele who are in the top 30 experts, which is an incredible achievement, really. Thinking about giant cell arteritis, what we've found, and this is part of James's work, was that non-classical symptoms can cause delay in diagnosis, and that means that people are then more at risk of all those sort of nasty things that can happen to people like visual loss. Certain symptoms and features may be present in people for up to 2 years before they actually get the diagnosis of giant cell arteritis. It's often thought of, a kind of an emergency kind of illness, but there's some evidence that's now emerging that actually it might be present long before people get that diagnosis. But I'll come to that in sort of future work. And during this time I got involved with something called the Clinical Research Network, which was an organisation through the National Institute for Health Research that supports delivering research. And so I've developed a sort of expertise, I suppose, in delivering research in primary care settings. And so through this, I could sort of progress through sort of various academic roles in terms of clinical lecturer and senior lecturer and prof. At this point, I will mention my dad, who sadly passed away, but... Sorry. But got to know that I knew this would happen. Got to know that I got promoted before he died. Right, 1 second. Anyway, moving on. Current research. I'm currently co-leading a study called the MEDAL trial. I've seemed to sort of got into this niche of doing back pain trials now. And I don't really know how that sort of happened, really, but I'm really proud of the fact that the MEDAL trial's taken a lot of work to sort of get going, but it's going to be the biggest trial of back pain interventions that's going on in the UK at the moment. And interestingly, I'm also involved in a colleague of mine called John Packham. He's doing a study called IDEAL, which looks at a suite of inflammatory back pain illnesses. And which is the problem with these illnesses is that there's a huge delay in diagnosis, and that can sometimes be 8 years. So the idea of the IDEAL study is that we're sort of trying to improve how quickly people get diagnosed with that. I've got to say thank you to Ruth, actually, and Christian for coming up with the idea of sort of maybe employing someone at MPFT who has got a primary care background and that's been an incredible journey as well. And we've sort of developed this group called Cosmic, massively supported by Paul Campbell, who I think is here tonight, and that really encompasses a whole range of community specialties in health and social care, and we've done loads of different projects looking at pharmacy and public health and nursing. It's a broad church of specialties, and one of the really interesting projects that's going on at the moment is Coast, where Paul is looking at routinely collected data for social care to do sort of big data research, which is something that hasn't really been done, but we do it kind of, I don't want to say all the time, but it's commonly done in health. So there's a couple of other studies, Badger. So Sterling is an interesting one because that's looking at different treatments rather than steroids for PMR. And I'm now part of the RDN, which is the Research Development Network, which used to be called the CRN, specialty lead for that. So moving on. So global health. I don't know if anyone sort of knows this place, but we'd come back from, Christian and I had just come back from Sri Lanka and we were sort of a bit high on this trip, and such a brilliant trip. And it was St. Patrick's Day, and I don't know why we were catching up, but we were walking past the Wetherspoons in New Toxteth, and I said, we've got to go in for a pint of Guinness because it's St. Patrick's Day. And anyway, we went in for a pint of Guinness and then got talking about global health and how we should start something in global health. So I like to think that our Institute of Global Health was born out of the Wetherspoons in New Toxteth. But Priya is now here and leading that brilliantly. And it's such a great, it's a really passionate area of mine. And it's such a great force for good, really. Some great studies that I've been involved with, including Eclipse. Had a PhD student that did a study on poise, which looked at burnout in family physicians internationally. And, I can't tell you how many collaborations we've created over the years, from Malaysia to Zambia to Montserrat to Guyana. It's just been a brilliant roller coaster of a ride. And as part of that, one of the things that I've sort of found, working with people internationally is that, again, general practice, particularly British general practice, is seen in such high esteem, and the absolute jewel of the crown in the UK in terms of healthcare because it's so efficient, and they really want to emulate general practice from the general practice in the UK. And I sort of got involved in this group that sort of looks to sort of promote general practice, globally, so that with the aim of sort of achieving universal health coverage. And it's such a great group to be on. So next steps, quickly coming to the end, hopefully. So in terms of PMR, like I've sort of said, PMR, the Keele PMR and GCA group, we're world leaders in this, absolutely. And, sometimes I think we should shout about that, a bit more, really. I think if you put, I don't know of any other organisation that's got so many people that are so highly ranked in terms of experts. But those new drugs that are going to going to take over from steroids are a long way off at the moment. So, we've really got to do the best that we have, and making the most of what we know, optimizing what we have, and then bringing that all together so that we can deliver a best practice package for our patients with PMR. And it's just really having a good think about how we can do that. I'm actually part of a group called Treat PMR, and this is a collaboration with Australia. And this is looking at how we can sort of create opportunities for innovative treatments for PMR to be delivered. It's really tricky because some of these treatments have to be delivered in a kind of secondary or hospital care setting, but all of the patients are in general practice, and so it can be quite tricky recruiting people to bring that sort of together. And there's clearly a lack of good quality drug trials for PMR. So giant cell arteritis, just quickly talk about that. Again, that sexy, cool illness that people like, that's part of PMR. So I was lucky enough to work with, meet someone called Kareem Raza, who Christian also knows, and he was really the godfather of this idea that the earlier that you pick up an illness, the sort of reduced amount of disability that they will suffer. And he had this graph, and this is not his original graph. I've had to sort of add something there, as you can see, my brilliant sort of technical skills. But the idea was that, actually, the y-axis there at years since symptoms start is when, people develop symptoms. But if you can extrapolate that line behind that, actually there might be an opportunity where you might be able to treat someone and them never actually develop the illness in the first place. And one of the PhDs that I supervised sort of suggested that there were some signals that were happening before people got diagnosed with giant cell arteritis. And we've done some preliminary work that actually says there's quite a few of these signals. The problem is, on their own, they're not diagnostic, but actually it may be that if you've got 10 or more signals, it might suggest that someone might have this giant cell arteritis, or, as a pre-diagnostic thing, or at high risk of developing it. So that's kind of exciting. It's just, we're in the stage of thinking, well, if we do manage to do this, what are we going to do with it? Because at the moment, we don't know if it'd be great to diagnose someone before they got symptoms, but actually there's no precedent for how you treat these people. And certainly the kind of algorithms and the quality of the electronic health records would absolutely allow this. And dare I say, AI is coming on as well. So I try not to mention AI, but it's with us. And I'm part of the British Society of Rheumatology, and we're developing the sort of latest guidelines for GCA. I'm doing some other stuff. There's been a big push towards commercial research in the UK, and general practice and primary care and sort of community settings is seen as a real opportunity because not a lot of research is being done in those settings at the moment. There's AI again, and we're sort of collaborating together to develop a study to look at AI in social care. There's huge kind of administrative burden in social care, and if you can take that off through these AI systems that can do that administration for you, it means that there's a lot more headspace for people working in social care. The Research Delivery Network continues, and I'm part of the National Informatics Solutions. I sort of co-lead that. And one of the very latest things is stalking harassment in general practice, which seems to be a massive, massive problem, but no one really talks about it. And that can be anything from just, sort of Facebook messages to, full on being stalked and followed home and stuff. But it's interesting, actually, because our sort of BMA and GMC and various other people just don't really know what to do about it. But that's a sort of bit of work that we're sort of looking at too. So thanks for listening. Be glad to know that I've come to the end. Just a few thank yous here. Christian, thank you for being there and sort of my managing my imposter syndrome from time to time, and going on some fantastic trips and just being the great mentor that you are. I know that you've supported so many people as well, but certainly I wouldn't be standing here without your support. Excuse me. Ruth, thank you for taking a punt on us. Your your zest for research and your vision is just incredible, and I think we're doing some great things at MPFT. My family, and I think some of them are watching tonight, but the 11 Kids on the Plane group, it started off as 3 kids on the plane, but now there's 11 of them, and some of them are wanting to have beers with us in the evening, so time has flown, and obviously sort of the Middleditch family, who are out there, and sort of my side of the family as well. And we've got some people, there's a picture here of Google Maps of Marston Montgomery. We've got some of the Marston Massive here who have been so welcoming of us to coming to the village, although our wall doesn't look quite as good at the moment. But, you know, they're brilliant, really supportive, and, you know, make sure every week that I really do not go over those 14 units of alcohol a week. And then, of course, you know, the girls and my wife. I'm going to finish there because I'm getting a bit tearful now again. But yeah, I think I've gone over my time, so I don't think we've got time for questions, have we? So safe journey home, and
Many congratulations, folks.